And looks like we are good to go, and we're recording. So, all right. Thank you, everybody, for joining us today. This is UNC Health's weekly media briefing. We've been doing these ever since April. I think this is our 22nd one. And today we're going to focus on emergency medicine and in emergency medicine education in particular, and also the practice of emergency medicine in the age of COVID-19. So we'll end up taking a look at today's medical students and residents and how they're being educated in emergency medicine during the age of COVID, and how care also has changed in the hospital and emergency departments due to COVID-19. So we'll get going, and just remember that afterwards we will upload unedited video and audio files that you can download for your use in news stories. So now for introductions, I will hand it over to my communications colleague, Tom Hughes. Tom?
Thank you, Phil. This week's featured guest will be Dr. Jane Brice, who is chair of the Department of Emergency Medicine within the UNC School of Medicine. Dr. Brice is a medical doctor, and she also holds a master's degree in public health. Dr. Brice has been named one of the most influential women in emergency medical services, and she has served as president of the National Association of EMS Physicians. She will be joined by colleagues within the UNC School of Medicine, Department of Emergency Medicine. She is student research director and adjunct professor of social medicine and epidemiology at UNC. Dr. Brice and company will focus on how COVID-19 has changed the way medical students are taught emergency medicine and how patients are treated in hospital emergency departments since the pandemic began.
And also, just to add on, we have two other folks joining us. Dr. Brice will be joined today by Christina Shenvy. Dr. Shenvy is Associate Program Director for UNC's Emergency Medicine Program, and will be joined by Dr. Jonathan Hancher, who is Chief Resident. So thank you, everybody, for joining us today. We really appreciate it. I think it will be helpful for media to see how we're handling emergency medicine, both in education and in practice today. And before we start taking media questions, Dr. Brice, could you just share some of your observations of how COVID-19 has affected both your educational program and the way care is provided?
Sure, I'd be glad to. The Department of Emergency Medicine stands on a couple pillars, and these are our areas of focus and attention. First and foremost, of course, is clinical care, the care of our patients, and the intersections between patients and their families and the healthcare system, and providing outstanding, excellent care to people who are in a time of need. Our second pillar, of course, is education. We run a very active and innovative education program, which includes all kinds of learners, resident physicians like Dr. Hancher, medical students, but learners of other varieties, nursing students, paramedic students, social work students who are learning about psychiatric emergencies. So we intersect with learners of all varieties. We also have a pillar of research, creating innovative ways to take care of patients and operating at the cutting edge of science. And then, of course, administration, financial stewardship, and things like that. Today, we're talking primarily about education, but I think the primary takeaway from here is that emergency medicine requires flexible, innovative, nimble thinking to be able to respond to the needs of our patients and to situations as they present themselves in the emergency department. And COVID has allowed us the opportunity to showcase our skills in that variety, in that way, in the areas of nimbleness and flexibility and ability to respond quickly to situations as they change. And I personally think that our department has done extraordinarily well in being able to respond in this area of COVID when everything is upside down, nothing is the way it was, and we have a brand new normal. But we've been able to maintain, to adhere to our principles of excellence, and to create new and innovative ways to respond to that. So having said that introduction, I will say I am not the star of this show. The star of this show is Dr. Shinby and Dr. Hancher, who are our leads in education. And so I'm gonna just turn this ship over to them. So go for it, guys.
Sure. Thanks, Dr. Brice. So I'm Christina Shenby. I'm Associate Program Director, and I also direct the third-year medical student rotation in the Emergency Department, and I direct the UNC Office of Academic Excellence. And I have to echo what Dr. Brice said. On the clinical side, we have been incredibly responsive and quick in how we've implemented changes as a department, and how she has led that. On the educational side, we've also had to change how we operate. And actually, we found some ways to educate our residents and our students in innovative ways that are in some ways even better than before. So when COVID began, we had to move all of our in-person education for residents to a virtual platform. The residents still work their shifts in the emergency department providing care, and so a lot of their education happens there at the bedside and in discussions with the faculty. But we did have 5 hours of educational time that we planned for them that was typically in person. And what we've done is used online platforms such as Zoom to meet virtually. And what that's allowed us to do is to actually then have speakers from all over the country who normally it would be time or cost prohibitive to have them fly in and give one lecture for them. But because now they're used to the virtual platform, we've been able to have individuals from Stanford or from other institutions give some of our lectures and content to the residents. And I think that's been very successful and actually a lesson that we will carry forward even after the isolation restrictions have eventually lifted. As far as the medical students, they were initially pulled from all clinical services for about 2 months, and then the fourth-year students were integrated back in, and then after another month, the third-year students were integrated back in from the medical school. And that was in part because there were a lot of unknowns about COVID and about how it spread and about how risky it was, and so they were very cautious in waiting until we had a safer plan to integrate students back in. However, now they are back in the hospital and in the emergency department. We are taking some extra precautions with students in terms of limiting their exposure to known positive COVID patients, but for the most part, their education is continuing and is thriving.
Great. Dr. Hancher, would you like to join in and just, you don't need to take yourself off of mute, but how has this affected your work and how are things different today from what you had thought they might be at this point?
So in terms of how it's affected our work, really it's mainly the triage process and the structure of our emergency department that's changed. It's not necessarily our approach to clinical care. So the only difference in our approach is we need to consider COVID-19 for almost all of our patients. And that led us to modify the triage process. So there's been a tent outside of our emergency department, and anybody who has concern for COVID-19 may be triaged to a different part of the emergency department. So that took some flexibility in scheduling. And then the only other big change in workflow is really the PPE. So donning and doffing with the correct PPE, whether it be an N95 mask and a gown and gloves, or just the universal precautions now, is really the big change. So when we see any patient in the emergency department, we are now wearing a face mask and eye protection. And if they're COVID-19 positive or we have high concern for COVID-19, we will don and doff with full PPE. It takes a little bit extra time, but we're very fortunate to work at UNC because it's an academic center. I think we're on the forefront of treating this disease. And we have had adequate PPE supplies the entire time. So we really do feel safe and like we're well stocked with PPE. And it's an exciting opportunity to train during a pandemic, just to learn the processes and collaborate with the other services in the hospital to figure out how best to treat these patients.
That's great. So let's open it up. If we have any media questions ready, folks from the media, just go ahead and step right up and ask your question. Hang on, I think I might see one there. Okay, I see one. Okay, I've got one in chat. Now this comes from Rose Hoban. Rose has problems with her microphone. But Rose is with North Carolina Health. And she says, she's asking, emergency departments are notoriously fluid environments. And she asked, what is one or two clinical interventions that may have changed or evolved since the beginning of COVID? And she gave an example and said, okay, in March, the advice was to ventilate quickly. And now it's more about high flow oxygen and proning. So are there some clinical interventions that you could point out that may have changed? And that could come from either any of the three of you.
Sure. Certainly the one that you mentioned is probably the most drastic, where initially people were saying you need to intubate early and quickly get these people on a vent. And then we were finding out that actually it's kind of paradoxical. A lot of times early intervention can help, but with COVID-19, it appeared that patients can tolerate a somewhat lower oxygen saturation than we would normally have as a goal, and avoid intubation, because what people found after, especially in New York and other places were very heavily hit, they found that often once the patient is ventilated, it's very hard to come off the vent. It's very hard to wean them off the vent and have them start breathing on their own again. And so then the thinking moved to more later intubation and tolerating a slightly lower oxygen saturation and just using high flow nasal cannula or other measures. Other things, initially people were saying, oh, we shouldn't use BiPAP because it may aerosolize it, and certainly we have to be cautious, but sometimes that can help or can stave off an intubation. I'll turn it over to my colleagues.
Yeah, I mean, I think that's a really great question, Rose, and spot on. I think what has happened since March, over the course of the past several months, is that we have had amazing support from our infectious disease colleagues and from our respiratory colleagues, pulmonary colleagues, in understanding how best to treat this disease. And we have learned an immense amount over the course of several months. And as you point out, that's the most prominent thing that has changed in the care of these patients. It hasn't really changed the way that we take care of other patients in the emergency department. But for this particular subset, it has definitely changed in exactly the ways you described.
Additional questions from the media. We'll go back and forth on our questions, but if the media have questions, please just jump right in. And if not, we've got another chat question. So here's one, and this is from Rose Hoban. So how do you handle changes to protocols in the educational process? And does that reinforce the need to stay current? Or does it confuse students and residents, or a little bit of both? What's your experience been on that?
Christina, I'm going to jump in on this, and then I'll let you back me up. So in terms of our protocol, so one of the things that has created some stress and anxiety for all of our providers, students, residents, faculty, nurses, is that literally our protocols change every single day, every day. Every day there is something new. And initially this was really distressful and difficult to manage. We very quickly initiated daily huddles. So every day, in fact, the reason that I didn't sign on to this call at 9:55 like you asked me to, Phil, was that I was on one of those calls. And so I spend 2 hours every single morning on calls with a variety of services, discussing clinical changes and discussing how we're going to change our management and make sure that we're taking excellent care of patients while remaining safe, which are our two priorities. And so we instituted a daily email to every single provider in our emergency department. We decided to go with a one voice model, which is that all information would come from a single individual so that there weren't a million emails descending upon our providers, and that all information was coming from one single trusted source. So we instituted a one voice model, and that has been extraordinarily effective. And we continue to do that to this day. We instituted weekly Zoom calls with every single provider. It was a department-wide call. Every single provider was expected to sign in, and these were recorded for those people who were working, or as you know, sleeping, because a third of our providers are working, a third of our providers are available, and a third of our providers are asleep because they worked all night. So these are recorded and available to providers to view it at their leisure and when they're available. So these department-wide calls then reinforce those changes. And a similar process has been instituted across UNC Healthcare, so that there is one voice putting out messages, and people know who to turn to and how to trust. There are also COVID resources available on all the web internet inside our internet, so not public facing, but employee facing intranet that people can access and are available in case there is a question or they feel like they missed an update. They can go and update themselves. So Christine, I'm going to turn it over to you.
Sure, thank you, Jane. The communications model that Dr. Brice has outlined has been incredibly effective to have a single voice that's delivering the material or the new information. One of the things that's been most important to me personally, and that I've tried to teach my residents and students that I work with, is that we have to learn to accept change. And often understanding that the way that I practice today is not the way that I'll practice tomorrow. What is okay today may not be okay tomorrow. The patient that I can't test today, maybe I can test them tomorrow, because our indications for who qualifies for testing have also changed rapidly. And so personally, being open to constant change is one of the things that I think many of us had to learn early on to be successful.
Dr. Hancher, do you want to comment on that? I mean, how has this constant change affected you as chief resident and the teams that you work with?
I think the biggest change, like we mentioned previously in terms of resident education, is the move from an in-person conference to a conference that's been on a virtual platform. And I would like to commend both Dr. Shenvy and Dr. Daniel Mark Walter, one of my colleagues who are in charge of our education, because we still have had stellar lectures and we still get great education every Wednesday morning on the virtual platform. In terms of, clinically how we've handled the change, I think it's an added stress for some people to wear PPE and deal with the pandemic in the emergency department. But it's about focusing on, what we can control. And that's wearing PPE for ourselves, making sure our patients have masks on, and that lowers our chance of, contracting any virus while we're working. And so really reassuring everybody. And the other things I want to say about how we've handled change, I think everybody's been so flexible, and in emergency medicine, it changes day to day. And I think that it draws a certain personality. So I've been very proud of my colleagues and co-residents, because I think they've showed immense courage and adaptability in the face of this pandemic.
We've got a couple of chat questions, which we'll get to from the media, but do we have any any live questions from media right now? Okay, we'll go to chat questions. So there has been, at least at one point, a major decline in the number of people that would show up in emergency departments because of concerns about contracting COVID. How dangerous is that thinking that it's not, that it might not be safe for me to go? I mean, we've really shown that it is, and in fact, it might be one of the safer places. But how dangerous is that thinking that it could be an issue, and so folks aren't going to the ED as well? Or what kind of numbers have you seen?
So that's a great question, and I just want for a second to jump off something you said, which is that it may be one of the safer places to go, because I think my colleagues may agree with me, but I feel safer in the emergency department than I do in the grocery store. Like, that is the safest place for me personally, because I know that everything is wiped down. I know that people are taking appropriate precautions. I know everybody has a mask on, and that is the thing that is protecting all of us. So I feel safer there than I do any other place in the community. But you asked about numbers. Our numbers did dramatically drop initially when COVID first hit the spotlight. That is no longer the case. Patients are seeking care in our emergency department. We are seeing our volumes return. We are currently at about 85% of our pre-COVID volumes, and that every week is increasing steadily. It is dangerous thinking to stay home when you're having chest pain or neurological symptoms or abdominal pain or vomiting blood or any of the other things that people were staying home and trying to wait out. We did see a period where we were taking care of patients who had stayed home and now were far sicker than they would have been if they had initially sought care. But that is mostly no longer the case. Those kinds of patients are fewer and farther between now, and patients are again seeking care appropriately. Dr. Hancher, did you have any thoughts about that? You're seeing patients every day.
I would just like to echo the same thing. I think a couple months ago, the volumes were a little bit lower, and we would see some people, for example, who had a urinary tract infection and waited to seek care because they had some fear of coming to the emergency department during a pandemic. And now they were sicker than they were when they just had a UTI. So we're not seeing that quite as much anymore. And people are seeming to seek care, and the volumes are definitely back up in the past couple weeks. So it seems to feel more normal during my recent shifts. It feels like a normal shift would have back before March.
Okay, all right. So question here is, have we had providers within the emergency department test positive for COVID and actually get sick? Is there anything there you can talk about?
So as you know, we had one physician provider who was on the news and has been on national news.
That's right.
Talking about his experiences with COVID.
Dr. McLean.
Dr. McLean.
Yes, we had
right.
him on the briefing a couple of weeks ago as well.
As far as other providers, that is confidential information, and I actually don't get to know those things. We do, of course, have providers who have exposures or are out for this or that. But as far as knowing who is has become COVID positive, that's actually protected information that I don't have access to.
Right. Gotcha. So, okay. If anyone wants to ask a live question, please go right ahead. If not, we've got several more also in chat that we can ask. Any live questions?
Hey, Phil, can I go back to that for just a second?
Absolutely.
I just want to give an enormous shout out to Erica Pettigrew and to Jim Hill from the occupational health divisions, both for the School of Medicine and for UNC Healthcare, because they work collaboratively together. And they have been amazing in working with our providers who have had exposures or who developed the sniffles or who are worried about family members who've developed the sniffles. And they have just been extraordinarily responsive and helpful. And it has increased their workload by a magnitude of just that's unimaginable. And I just can't say enough amazing things about their ability to keep us safe and to provide us with good guidance.
Right. So this is more of a general question, and so anybody that would care to, please jump in on this one. And this is coming in. It says the state might move forward with stage 3 of the reopening plan. Governor Cooper would actually probably will have an announcement today. Are you as being on the front lines as you are, is that a concern that healthcare systems might get inundated when society opens up a little more?
All right, so I'm going to jump in and just briefly, and then Dr. Shinby and Hancher jump in if you feel the need. But I trust implicitly Mandy Cohen and Governor Cooper. I think they have done an amazing job in guiding our state, in keeping us safe, in keeping this disease manageable. They work from science and from data, which is near and dear to my heart as well. I just can't say enough amazing things. If Governor Cooper and Mandy Cohen think it's time to move to the third level, then I'm in. We will manage this. We will make this work, because they have done a really amazing job, and I am following their lead.
Dr. Sancher and Shinby, do you have any other thoughts? I mean, I know you're there as well, seeing patients.
No, I agree with Dr. Brice. I think individuals should still continue to take precautions, wear their masks, avoid large gatherings. But I think there's also a lot of realization, and a number of articles have been published recently about some of the potential unintended consequences of more severe or extreme lockdowns. For example, a number of articles have been published recently on the potential impact of career success for women and gender gaps there, because women, not exclusively certainly, but many women are finding that they're now having to work full-time from home in addition to providing full-time childcare, and there are concerns about could this widen the achievement gap or the promotion gap, or make it harder for them to gain career success or promotion during this year or more that they are working from home because of the pandemic.
Great. Any thoughts on that, Dr. Hancher?
You know, I'd just like to echo what Dr. Brice said. I think I have immense respect for our leaders. For me, Dr. Shenby, Dr. Brice, and others in our department who are making our decisions and leading our department. And then on the next level is Governor Cooper. And so if they're ready to make a decision and move towards phase 3, we will do our best to work with them and do what we can as health professionals to serve the people of North Carolina.
Great. Well, believe it or not, we're almost out of time. It always goes really fast. This has been fascinating. So we've got just a couple of minutes left. I mean, we could go as long as we need to. That's the good part about Zoom meetings, especially when you pay for it. Any last thoughts on how emergency medical education has already changed and will continue to change in the area of in the age of COVID, I guess I should say? Any of the three there want to comment on that as we conclude?
For me, all of the rapid changes, both in education and clinical practice, have highlighted the critical importance of resilience in medicine. It's something that has been talked about, resilience, burnout, et cetera, but really how you adapt to rapid change and higher risk situations has a lot to do with resilience. And so for me, it's highlighted the fact that we need to continue to move forward with that in teaching it and researching it and understanding it and implementing it and creating systems that support it, and helping relieve the burden on the individual physician by creating systems that are able to promote better resilience and wellness.
Great. Well, we are out of time. It is 10:30. So thank you, Dr. Brice, Dr. Shenby, Dr. Hancher, so much for joining us. This is fascinating to get your perspective. To our friends in the media that have joined us, thank you for being here today. And what we will do is we always do. We will post an unedited version of the audio and the video files from today's briefing, and that will be available for you hopefully within the next 30 minutes. I'll send out a Dropbox address and you can download directly from there, and then we will have another briefing next week at this time. And so that does conclude our media briefing for today, and thank you all for joining us. Thanks.
Thank you.